Welcome back to lectures in endocrinology. Today we'll be discussing lecture 6 of endocrinology, where we get to look at the parathyroid hormone, calcitonin, calcium and phosphate metabolism, vitamin D, and the bone physiology. Of course, this lecture is loaded with a lot of information, so I'm not going to complete the entire lecture video in one session. I'm going to split it into two parts. The first part, we are going to just discuss the calcium and phosphate metabolism and also bone physiology. Then the last part of the video, that's where we're going to discuss the parathyroid hormone and vitamin D. And of course, disorders associated with the calcium metabolism. So hyperparathyroidism and hypoparathyroidism. We are going to discuss that in the last part of the lecture. So now let's start with the first part of the lecture. So let's have a look at the overview of calcium and phosphate regulation in extracellular fluid and plasma. So we need to regulate calcium and phosphates, especially that of calcium. Calcium concentration is normally regulated precisely at 2.4 millimole per liter. This normal concentration of calcium in the extracellular fluid needs to be maintained. So there are reasons why we need a precise control of calcium concentration, because calcium has got a lot of functions. You know, to say calcium is needed for muscle contraction, be it smooth muscle, cardiac muscle, and skeletal muscles. We need the calcium to go and bind to camodulin or troponin C for you to have smooth muscle and skeletal or cardiac muscle or contraction, respectively. But also you need calcium when it comes to transmission of neurotransmitters at the synaptic cleft. So synaptic transmission of nerves or nerve cells are able to communicate with one another via the release of neurotransmitters. So you need the calcium to facilitate the exocytosis of neurotransmitters that can go and bind to postsynaptic membrane to trigger another action potential there. And you also need calcium when it comes to clotting mechanisms. Calcium is going to participate in the extrinsic and intrinsic clotting mechanism, and also the common pathway of clotting mechanism. You need calcium. So calcium is needed. Calcium plays a key role in many physiological processes, which I have already mentioned, including the contraction of skeletal, cardiac, smooth muscles, blood clotting mechanism, transmission of nerve impulses. I've already explained why you need calcium to be controlled. Excitable cells such as neurons are very sensitive to changes in calcium ion concentration. Increases in calcium ion concentration above the normal, which is referred to as hypercalcemia, causes progressive depression of the nervous system. If you have an increase of calcium in the extracellular fluid compartment, that calcium can cause depression of the nervous system. Why? It's because the permeability of the membrane to sodium is dependent on calcium concentration. So if you have a lot of calcium in the extracellular fluid compartment, that will cause the nervous system to become impermeable to sodium. That will also cause depression of the nervous system, because now for you to initiate action potentials, it will be very difficult. Sodium won't be entering the nervous cells, so that in itself will cause depression of the nervous system. The firing of action potentials will be less. Decreases in calcium concentration, hypocalcemia, cause the nervous system to become more excited. The nervous system will be very excited if there is hypocalcemia. In hypocalcemia, you have less calcium in the extracellular fluid compartment. If you have less of calcium, then the neurons become more permeable to sodium. Sodium will be entering the cell. There will be a lot of sodium influx that will cause depolarization. There will be some kind of depolarization taking place, that will cause the resting membrane potential or the neurons to move closer to the threshold potential for firing action potentials. Because of that, it will be very possible to fire action potentials, so the nervous system will get excited in hypocalcemia. About 0.1% of total body calcium is in the extracellular fluid, and about 1% is in the cells and its organelles, and the rest of calcium is stored in the bones. So the bone is very important reservoir of calcium. So the bone will participate in regulating the calcium levels in the extracellular fluid compartment by mobilizing calcium and phosphates from the bone, or cause bone deposition of these minerals if they are in higher concentration. So the bone will act as a reservoir for the minerals, especially for calcium and phosphates. Approximately 85% of the body's phosphate is stored in the bones. So most of the phosphate in the bone, they are stored in the bone, in the body. 14 to 15% is in the cells, and less than 1% is in the extracellular fluid. So 85% is found in the bone, 14 to 15% is in the cells, and less than 1% is actually located in the extracellular fluid compartment. But with regard to calcium, we are saying only 0.1% of calcium is in the extracellular fluid, 1% is in the cells. But you realize that the concentration of calcium in the cytoplasm is almost zero. So the 1% of calcium that is found in the cells mostly is found in the cell organelles. So remember, you have cell organelles that can store calcium, but the cytoplasm of the most cells, the concentration of calcium is almost zero, because it's 0.0001 milliequivalent per deciliter. The solution: calcium in the plasma and interstitial fluid. The calcium in the plasma is present in three forms. So there are three forms of calcium. We have 41% of calcium that is combined with plasma proteins, and in this form is non-diffusible through the capillary membrane. The calcium that is found bound to plasma proteins, the plasma proteins are confined within the cardiovascular system, so they don't leave the cardiovascular system. All the calcium that is bound to the plasma proteins will still be confined within the cardiovascular system. That's why we are saying it's non-diffusible through the capillary membrane. Then we have the 9% of calcium, which is diffusible through the capillary membrane but is combined with anionic substances or the plasma and interstitial fluid, the citrate and phosphates. These are negatively charged ions. So the calcium that is bound to these negatively charged ions is diffusible, but it's not ionized calcium. So it's not ionized calcium. The remaining 50% of calcium, giving you the concentration of 1.2 millimole per liter in the plasma, is both diffusible through the capillary membrane and ionized. So this is the ionized calcium, the form of calcium which is very important for those functions that we are discussing. So the functions of calcium, it's very important that the calcium should be in ionized form. So only the 50% of calcium which is ionized will be available to give you those functions in contraction, transmission at the synapse, and also participating in blood clotting mechanism. So all those functions, you need this calcium to be in ionized form. Then it will be diffusible across a plasma membrane, so it can move from the cardiovascular system into the interstitium, from the interstitium into the cells, then to provide you with those functions. This is just a chart that is summarizing the functions or the types of calcium that is there in the body. We say 9% of the calcium is complexed with anions, so 9% is complexed with anions. We have 41% that is protein-bound calcium. Then the 50% is an ionized calcium. So the ionized calcium is the one that is very important with regard to those functions. Inorganic phosphates in the extracellular fluid, they will exist in two forms. We have hydrogen phosphates and dihydrogen phosphates. So these are the ones that are referred to as phosphate buffer. Phosphate buffer. So the phosphate buffer, we have the two forms. We have hydrogen phosphate and dihydrogen phosphates. Dihydrogen phosphate simply means that there are two hydrogen ions that are bound to the phosphate. If you only have hydrogen phosphates, then it's only one hydrogen. So this will act as a buffer system because it can accept hydrogen ions or it can donate hydrogen ions. In case whereby the pH is reducing, it's becoming acidic, you know to say that what you're going to have more is dihydrogen phosphates because you have a lot of hydrogen ions. So the phosphates will be accepting a lot of these hydrogens. So you find that most of these phosphates will be dihydrogen phosphates. When the pH is becoming alkaline or it's increasing, then you'll be having more of hydrogen phosphates because most of the hydrogen, they are being donated by the phosphates. When the pH or the extracellular fluid becomes more acidic, there is a relative increase in dihydrogen phosphate and decrease in hydrogen phosphate and vice versa. So this I've already explained what is happening there. Hypocalcemia causes nervous system excitement and tetany or muscle tetany. So I've already explained why hypocalcemia will cause an increase in the excitability of the neurons. So it will cause nervous system excitement. So the excitement is going to increase. That can result into muscle tetany because there are uncontrollable firing of action potentials, spontaneous action potentials that can go and stimulate muscle contraction. So that will result into muscle tetany as well. When the extracellular fluid concentration of calcium ion falls below normal, the nervous system becomes progressively more excitable because this causes increased neuronal membrane permeability to sodium ions. I've already told you to say if you have hypocalcemia, the membrane of the neurons become more permeable to sodium ions, allowing easy initiation of action potential because the influx of sodium will depolarize the neurons. Then they can easily fire action potential. Hence, they become excited. At plasma calcium ion concentration about 50% below normal, the peripheral nerve fibers become so excitable that they begin to discharge spontaneously, discharging of action potentials. Consequently, hypocalcemia causes tetany and seizures. So you have muscle tetany and seizures as a result of hypocalcemia, which you can see. So on clinical signs, you have Trousseau sign. So signs of hypocalcemia. We have Trousseau sign where you have involuntary flexion of the digits and also you have extension of the digits and flexion of the wrist. So the wrist, you have flexion of the wrist and you have extension of the digits. This is called Trousseau sign. So the Trousseau sign is as a result of hypocalcemia that will cause misfiring of action potentials. Then that will result into contraction of muscles of the digits. So you can see that Trousseau sign as due to hypocalcemia. So when you are taking blood pressure, you are going to put a cuff there that can stimulate nerve fibers to fire, and those nerve fibers will cause the Trousseau sign. So you can always see it when you're about to take blood pressure. It will be enhanced when you're taking blood pressure. Then the other sign is called the chopstick sign. The chopstick sign is whereby when you're tapping the facial nerve, then there is contraction of the facial muscles. So the facial muscles will contract to give you that facial expression when you're tapping, as if somebody has got Bell's palsy. Bell's palsy. So that is due to hypocalcemia. The neurons will become very excited. When you're just tapping on them, then they'll fire action potentials that will cause contraction of some muscles. So that is called the positive chopstick sign. So when you're tapping the facial nerve, then you can see contraction of some muscles that will cause somebody to appear as though they have Bell's palsy. So when there's damage also to the facial nerve, that can cause continuous firing on the facial nerve, then stimulating these muscles, then you can see that somebody can have Bell's palsy. You have seen people who've been undergo maybe surgery or maybe it was an accident, then there was damage to the fascial nerve, then they have Bell's palsy. Okay, so you encounter some patients with Bell's palsy. So just think of the fascial nerve. Sometimes it can be due to hypocalcemia. Hypercalcemia is the opposite now. The hypercalcemia depresses the nervous system and muscle activity. So there is depression of the nervous system in hypercalcemia, because we said the permeability is going to reduce. So the permeability to sodium is reduced. Then it's very difficult to depolarize these neurons. Then the activities will reduce. So there will be depression of the nervous system and muscle activity. When the level of calcium in the body fluids rises above normal, the nervous system becomes depressed and reflex activities of the central nervous system are sluggish, so they will be slow. There will be decrease in the QT interval of the heart, and also lack of appetite and constipation. So constipation is because you're not sending a lot of action potentials to the GIT, the motility is reduced. If the motility is reduced, you know to say there will be constipation there, and also lack of appetite. Absorption and excretion of calcium and phosphates. Intestinal absorption and fecal excretion of calcium and phosphates. The usual rates of intake are about 1000 milligrams per day for calcium and phosphates. So every day you are introducing about 1000 milligrams of calcium per day or phosphates per day. So this is the calcium that you are introducing via the fluids that you are drinking or the food that you are eating. There could be some calcium there. So every day you're introducing 1000 milligrams of calcium and phosphates into the GIT or into the body. Vitamin D promotes calcium absorption by the intestines. Vitamin D, of course, is going to encourage absorption of calcium in the intestines, and about 35% of intestinal calcium is usually absorbed. So out of the 1000 that you're introducing, the mucosal cells, the intestinal mucosal cells, they are only going to absorb about 35% of calcium under the influence of vitamin D, that is activating the enzymes that are involved in absorption of calcium. An additional 250 milligrams per day of calcium enters the intestines via the secreted gastrointestinal secretions and sloughed mucosal cells. So from the sloughed mucosal cells and also the secretions of the gastrointestinal fluids, they can also contain some calcium. So you are secreting about 250 milligrams per day of calcium into the lumen of the GIT. That simply means that the amount of calcium that you are reabsorbing, there is a net absorption of calcium, which is about 100 milligrams per day. Because if you subtract 350 minus what you are secreting back, 250, it will give you about 100 milligrams of calcium that is being absorbed into the body itself. About 90% or 900 milligrams of daily intake of calcium is excreted in the fecal material or in the feces. So about 900 milligrams per day is being excreted. What you are absorbing overall is about 100 milligrams. You absorbed 350, you secreted 250. So the net absorption of calcium is 100 milligrams. So out of the 1000 milligrams, you are excreting 900 milligrams. The only amount of calcium that you are absorbing is 100 milligrams. Intestinal absorption of phosphates occurs easily. So almost all the phosphates that you're introducing to the GIT is going to be absorbed. Then later on, it will be excreted in the urine according to the overflow of phosphates. So there is control of phosphates concentration in the body. If you have excessive amount of phosphates, much of it will be excreted by the kidneys in the urine. That's what I mean. Renal excretion of calcium and phosphates. Approximately 10% of ingested calcium is excreted in the urine. So the same 10% that was ingested is going to be excreted in the urine to maintain the steady state concentration of calcium, because the body has got its own calcium. So if you are absorbing the 100%, you are absorbing 10% of calcium, the same 10% has to be excreted so that the levels of calcium within the body are maintained. Otherwise, if you are gaining or you are losing, then you end up with hypercalcemia or hypercalcemia or hypocalcemia. Calcium bound to plasma proteins is not filtered by the glomerular capillaries. So the calcium that is bound to plasma proteins, of course, is not going to be filtered by the glomerular capillaries. It will be confined within the cardiovascular system, which simply means that the calcium that will be filtered here is the diffusible calcium, that which is binding to anions and that which is ionized calcium. The 9% and the 50% can be filtered. Calcium bound with anions such as phosphates or ionized is filtered through the glomeruli into the renal tubules. Renal tubules reabsorb 99% of the filtered calcium. So out of this calcium that is being filtered, 99% will be reabsorbed back into the body because it's still needed by the body. 90% in the proximal tubules, loop of Henle, and airy distal tubules. 10% of reabsorption is taking place in the late distal tubules and airy collecting ducts, which is selective depending on the calcium ion concentration in the blood. So this is where the duration of calcium is coming in. So if you have a lot of calcium in the blood, this 10% will reduce. If you have less of calcium, then you'll be reabsorbing 10% in this portion of the kidney nephron. Renal phosphates excretion is controlled by an overflow mechanism such that reduced reabsorption when plasma phosphates concentration is high and vice versa. So if you have a lot of plasma phosphates, then there will be an overflow of phosphates that will be excreted in the urine. If you have less of phosphates in the blood, then there will be more of reabsorption taking place in the kidneys. This is just to summarize what is being introduced into the GIT and what you are excreting in the body. So we say that we have calcium in the cells, calcium in the extracellular fluid, and then calcium in the bone. The calcium that is in the cells, we said 1%, extracellular fluid 0.1%, then in the bone, the rest of the calcium is found in the bone. So you can say in the bone you have more calcium, 1 million calcium, 1 million milligram of calcium is found in the bone, 13,000 milligram in the cells, 1,300 milligrams is found in the extracellular fluid. So there is exchange of calcium between the cells, extracellular fluid, and the bone tissue, which you can see happening here. You are introducing 1,000 milligrams of calcium per day into the GIT. 350 milligrams is being absorbed in the GIT to go into the extracellular fluid compartment. Then you are also secreting about 250 milligrams per day. So the overall reabsorption, the overall absorption of calcium is only 100 milligrams per day, which means that what is being excreted here is 900 milligrams. Out of this 1,000, what you're absorbing is only 1,000. It's only 100 milligrams. 100 milligrams is being absorbed here. Then the 900 milligrams is excreted in the fecal material. But you can see that from the extracellular fluid there is exchange. So some of this calcium that is found in the extracellular fluid is being filtered in the kidney nephron. 9,980. So you are filtering about 9,980 milligrams of calcium. So this is what is being filtered. 9,980 milligrams of calcium is being filtered. 9,980 milligrams is being filtered here. And out of that, 99% we are saying it's being reabsorbed. So you can see here, 9,880 is being reabsorbed back into the body. And what is being excreted is the difference between the two, which is 100 milligrams. So only 100 milligrams of calcium is being excreted in the urine, which makes sense because here the overall absorption was 100 milligrams If you want to maintain these concentrations within the body, it means you need just to lose 100 milligrams of calcium per day. So this is the interaction. But you can see between extracellular fluid and the bone tissue, there is bone deposition of minerals like calcium, 500 milligrams per day. Then you are also mobilizing calcium from the bone. So we have bone resorption that is taking place. 500 milligrams per day is also being removed from the bone to the extracellular fluid. So there is exchange of calcium from the intracellular to the cells, or from the extracellular to the bone. So this is just the exchange of calcium. Moving on to bone physiology. So you might have covered this in anatomy and also in biochemistry, but here we are interested in bone physiology. So we'll just be adding on to the information that you discussed in the other courses. But remember, the skeleton is composed of the bones, and we've already said that the bone is going to function as a reservoir for minerals like calcium, phosphates, magnesium, and bicarbonates that you can also find within the bone as mineral deposits into the bone. So you are able to mobilize these minerals from the bone, and if you have excessive amount of these minerals in the body, you can deposit the minerals to the bone. So there's bone deposition, there's also bone resorption that will mobilize the minerals from the bone. The bone cell types, there are 4 major types of cells that you're going to find associated with the bone. The first one is the osteogenic cells, which are the stem cells. The osteogenic cells are the stem cells that can differentiate into different types of bone cells. Then we have the osteoblasts. The osteoblasts are the bone building cells. They are going to secrete the matrix and also the collagen fibers. So these are the ones that are depositing the bone material on the bone. We have the osteoclasts. The osteoclasts are the mature bone cells that no longer secrete the matrix. So the same osteoblasts, sometimes they can be trapped by the bone tissue. Then they'll be embedded within the bone tissue. Then they'll become the osteocytes. The osteocytes are the mature bone cells that no longer secrete the matrix. And the last type of the cells are called the osteoclasts. The osteoclasts are the ones that are causing bone resorption. So they are involved in bone digestion to mobilize the minerals from the bone tissue to the extracellular fluid compartment. So these are the different types of cells that are found within the bone. The structural basic unit of the bone tissue is called the osteon. So you can see the osteon that is composed of the central canal. The central canal is housing the blood supply, the nerve supply, and also lymphatics. Then we have the canaliculi, which is the concentric layers of bone tissue composed of the matrix and the minerals that are deposited into the bone. Then in different segments of the osteon, you can see the osteocytes, which are the osteoblasts that are entrapped within the bone tissue itself. So this is the structure of the bone. So the basic structural unit of the bone, we said, is called the osteon. So the osteon is composed of the central canal at the center there, where you find the artery, the vein, and the lymphatics. Then you can also see the nerve that will supply the bone itself. Then surrounding the central vein, we have layers of the bone tissue, which are called lamellae. So you can see the lamellae that is just surrounding the central vein, forming concentric layers of the bone tissue, entrapping the osteocytes. Then the outer surface of the bone, we have the osteoblasts that are depositing the bone tissue. Then we also have the osteoclasts that are digesting the bone tissue itself. Then within the bone tissue, we also have bone cavities, and those cavities you can find either the osteoblasts or the osteoclasts. So the osteoclasts will be the first ones to digest the bone, then you can find the osteoblast will come in to deposit new bone tissue or new bone material. Bone and its relation to extracellular calcium and phosphates. So the bone and its relation to extracellular calcium and phosphates. Average compact bone contains by weight about 30% matrix, 70% salts. So an average bone, a compact bone, will have more of salts as composed to the matrix. The collagen fibers will be less as compared to the minerals. So 30% matrix, 70% salts or minerals. That will be the compact bone. But the newly formed bone may have a considerably higher percentage of matrix in relation to the salts. So here, because this is when the bone is being deposited, it will have more of the matrix as compared to the salts. The organic matrix of the bone, that is being deposited by the osteoblasts, the organic matrix of the bone is 90 to 95% collagen fibers, and the remainder is homogeneous gelatinous medium that is called the ground substance. So 90 to 95% we have collagen fibers, and then we also have the ground substance of the bone, the collagen fibers give the bone its powerful tensile strength for this bone not to bend. So there is that tensile strength that will prevent the bone to be stretched or to bend. It's because of the collagen fibers. The ground substance is composed of extracellular fluid plus proteoglycans, especially chondroitin sulfate and hyaluronic acid. So these, the proteoglycans, are found within the ground substance of the bone. The ground substance of the bone will contain a lot of proteoglycans. The bone salts, these are the minerals that are deposited into the bone tissue. The crystalline salts deposited in the organic matrix of the bone are composed principally of calcium and phosphates, the hydroxyapatite. So the deposits of minerals, mainly calcium and phosphates, will form the hydroxyapatite of the compact bone. Mainly, remember, we have the compact bone and also the spongy bone that contains a lot of cavities, especially near the epiphysis of the bone. That's why you find the spongy bone or soft bone. Magnesium, sodium, potassium, and carbonate ions are also present among the bone salts. The bone salts conjugated to hydroxyapatite. So on top of the calcium and phosphates, you can also find magnesium, phosphates, potassium, and bicarbonates. The tensile and the compressional strength of the bone. The collagen fibers of the bone have great tensile strength, whereas the calcium salts have great compressional strength. So when you're talking about the strength of the bone, the collagen fibers, I've already told you to say they are going to provide the tensile strength of the bone so that they are not stretched or they can't bend. But on top of that, you have the mineral deposits that will provide the compressional strength of the bone, so that even if when you're standing up, the bone can't be compressed. Why? It's because of the minerals that will provide the compressional strength to the bone. The hydroxyapatite does not precipitate in the extracellular fluid despite supersaturation of calcium and phosphate ions. This is because we have inhibitors. Inhibitors like pyrophosphates, they will prevent precipitation. So the hydroxyl does not precipitate in extracellular fluid despite supersaturation of calcium and phosphate ions. The hydroxyapatite is only going to precipitate within the bone tissue, because in the bone tissue you don't have the inhibitors like the pyrophosphates. So the minerals will precipitate in bone tissue, but in other soft tissue like blood vessels, clots, you find that you won't find precipitation of these bonds. Why? It's because in normal tissue we have the inhibitors, the pyrophosphates, that will inhibit the precipitation of the hydroxyapatite, even if you have supersaturation of calcium and phosphates. Therefore, hydroxyapatite crystals fail to precipitate in normal tissue except in bone despite the state of supersaturation of ions. So even if you have supersaturation of ions in other normal tissues, you can't find precipitation of the hydroxyapatite. But under abnormal circumstances, like in blood clots or tissue that is undergoing necrosis, sometimes you can find that there will be precipitation of bone there. So you can find a bone at the center of the clot, or you can find a bone maybe within the GIT itself. Why? It's because maybe there's necrosis taking place, there's less amount of bone precipitation inhibitor, which is a pyrophosphate, then the hydroxyapatite will start precipitating in those tissues which are abnormal. Mechanism of bone calcification. Calcification of bone, meaning that you are talking of deposition of minerals to the bone, especially the calcium. The initial stage in bone production is the secretion of collagen molecules called the collagen monomers and the ground substance, mainly the proteoglycans, by the osteoblasts. The osteoblasts are the ones that are depositing the ground substance and the collagen fibers. The collagen monomers will polymerize rapidly to form collagen fibers. The resultant tissue becomes an osteoid. An osteoid is when the collagen fibers have polymerized to form the collagen monomers. They are going to polymerize to form the collagen fibers. Then the resultant is the formation of the osteoid. As the osteoid is formed, some of the osteoblasts become entrapped in the osteoid and become quiescent, meaning that now they are not active. At this stage, they are called osteocytes. So those osteoblasts that are entrapped within the ground substance and the collagen fibers, they will become the osteocytes. They are no longer active. They are no longer depositing the bone materials. Within a few days after the osteoid is formed, calcium salts begin to precipitate on the surface of the collagen fibers. The initial calcium salts to be deposited are not hydroxyapatite crystals but amorphous compounds, non-crystalline, which is converted into the hydroxyapatite crystals over a period of weeks or months. So now the first minerals that are deposited there, they are not in hydroxyapatite form, but they are called amorphous compounds. The amorphous compound, they can easily be mobilized to be released to the extracellular fluid compartment, but later on they will crystallize to form the hydroxyapatite, and then there will be more deposition of the minerals. A few percent may remain permanently in the amorphous form. This will provide means by which now the minerals can be exchanged between the interstitial fluid and the bone tissue, or the extracellular fluid and the bone tissue. This is important because these amorphous salts can be absorbed rapidly when there is need for extra calcium in the extracellular fluid, which I've already explained. Precipitation of calcium in non-osseous tissues under abnormal conditions. I also mentioned to say when there is necrosis or blood clots, you can have calcification of hydroxyapatite, because now there we have less of pyrophosphates that will inhibit precipitation. So precipitation can take place there. Under abnormal conditions, calcium salts precipitate in normal tissue besides bone. For instance, they precipitate in arterial wall in arteriosclerosis. So if you have hardening of the arterial walls, then you can have precipitation of minerals there that will result into bone formation. Likewise, calcium salts frequently deposit in degenerating tissue or in old blood clots. So old blood clots, you can have deposition of minerals there that will now start producing a bone within the clots. So in most cases, it's because the inhibitor factor will disappear from the tissue, thereby allowing precipitation to take place. So if the inhibitor, the pyrophosphate, is not there, precipitation will take place. Calcium exchange between bone and the extracellular fluid. So the amorphous type of minerals are the ones that are being exchanged with the extracellular fluid. Bone contains a type of exchangeable calcium that is always in equilibrium with the calcium ions in the extracellular fluid. Exchangeable calcium amounts to about 0.4 to 1% of total bone calcium. This calcium is deposited in the bones in the form of readily mobilizable salts such as amorphous calcium salts, like I've already explained. It provides a rapid buffering mechanism to keep the calcium ion concentration in the extracellular fluids within the normal limits. So the normal control of calcium concentration in the extracellular fluid is provided by the amorphous type of calcium that can easily be mobilized from the bone tissue to the extracellular fluid. The deposition and absorption of bone, which is called remodeling of bone, it's very important for the normal function of the bone. There are cells that are depositing the bone, there are cells that are removing or digesting the bone itself. So the digestion of the bone tissue provides cavities in which new bone material can be deposited. That will maintain the tensile strength and the compressional strength of the bone. Bone remodeling. Bone is continuously being deposited by the osteoblasts. The osteoblasts are found on the outer surface of the bones and in the bone cavities. Bone is also being continually absorbed in the presence of osteoblasts. Bone absorption takes place by the osteoclasts. The osteoblasts are the ones that are depositing the bone. Bone is also being continually absorbed in the presence of the osteoclasts, which are large phagocytic multinucleated cells, derivatives of monocytes or monocyte-like cells formed in the bone marrow. So they are formed in the bone marrow. When they migrate to the bone tissue, they will become osteoclasts. So these osteoclasts are the ones that are absorbing the bone tissue during bone resorption. So they are large phagocytic multinucleated cells that can produce a lot of enzymes that are involved in the digestion of the bone and also release of acids. This diagram is summarizing the types of cells and their functions. So you can see the osteoblasts that are on the surfaces of the cell or the bone and within the bone cavities. These are the ones that are depositing the ground substance and the collagen monomers that will polymerize to form the collagen fibers. Within the cavities, we have the osteoclasts. The osteoclasts are digesting the bone, the old bone. So the old bone is digested by the osteoclasts, creating the cavities. Then the osteoblast will come in to deposit new bone. So this is called remodeling of the bone. Then at the center, of course, we have the central canal where we have blood vessels, nerves, and lymphatics. Okay, this diagram I'll explain after the next slide because it's explaining about the information that we'll discuss in the next slide. But in simple terms, we have the osteoclast precursor. The osteoclast precursor are the cells that will differentiate into osteoclasts. But for them to differentiate, they need a ligand that is being produced by the osteoblasts. The osteoblast produces a ligand that will go and bind to osteoclast precursor cells, activating them. Then they will differentiate into the osteoclasts. So we have the activated osteoclasts that will start digestion of the bone, but they need a ligand that is produced by the osteoblasts. So I'll explain after the next slide. The mechanism of this absorption is believed to be the following. So the absorption of the bone is believed to be the following. The osteoclast sends out villus-like projections towards the bone, forming a ruffled border adjacent to the bone. So you can see the ruffled border adjacent to the bone. The villi secretions. So the villi, they are going to secrete proteolytic enzyme released from the rhizosome or the osteoclast. The osteoclast, they contain a lot of rhizosomes. Then when they develop the ruffled border, these are finger-like projections which are called the villi. That's where they will be secreted. So they are secreting a lot of enzymes from the lysosomes. Then they are also secreting several acids, including citric acid and lactic acid. So you can see the citric acid and lactic acid is being secreted from the mitochondria and the secretory vesicles by the osteoclast. The enzyme will digest and dissolve the organic matrix of the bone, and the acids will cause dissolution of the bone salts, the minerals. So you need the enzyme to digest the organic matrix, which is the collagen and the ground substance. Then we have the acids that will cause dissolution of the minerals, the salts now, the calcium, phosphates, magnesium, potassium, and others. The parathyroid hormones, they are going to stimulate osteoclast activity and bone resorption. How? What's the mechanism there? So we are also going to discuss this when we start looking at parathyroid hormone in parathyroid gland. The parathyroid hormone binds to receptors on the adjacent osteoblasts. So the parathyroid hormone doesn't actually bind to osteoclasts. It has got receptors on the osteoblasts. The parathyroid hormone will bind to receptors within the osteoblasts. They have receptors for parathyroid hormone. Then the osteoblast will release cytokines. Once parathyroid hormone binds to osteoblast, it will activate the osteoblast to start releasing cytokines, including the osteoprotegerin ligand. The osteoprotegerin ligand is going to bind to pre-osteoclasts. So these are the precursor for osteoclasts before they are activated. The osteoprotegerin ligand activates the receptor on the pre-osteoclast cells, causing them to differentiate into the mature multinucleated osteoclasts. That will now release the enzymes in the acids to start digesting the bone, causing bone resorption. The mature osteoclast then develop a ruffled border and release enzyme and acids that will promote bone resorption, which I explained. The osteoblast also produced osteoprotegerin. This is a protein ligand, not necessarily a ligand like the one which is being produced here, but this is another protein that is being produced. So the osteoblast also produces the osteoprotegerin protein, sometimes called osteoclastogenesis inhibitory factor. The osteoclastogenesis inhibitory factor, a cytokine which inhibits bone resorption. So this is more like control. It will control the osteoclast not to over digest the bone. So the same osteoblasts that can activate the pre-osteoclast to mature osteoclast, then they will start digesting the bone under the influence of osteoprotegerin ligand. They can also produce the osteoprotegerin. This is different from the ligand. It's inhibitory, so it's going to inhibit the activity of osteoclasts to minimize bone digestion. So they are also referred to as osteoclastogenesis inhibitory factor, a cytokine which inhibits bone resorption. The osteoprotegerin acts as a decoy receptor, binding to osteoprotegerin ligand and preventing osteoprotegerin ligand from interacting with the receptor, thereby inhibiting differentiation of pre-osteoclast into mature osteoclast that absorb the bone. So there is control here. We are saying for the osteoclasts to undergo differentiation, you need parathyroid hormone to go and bind to osteoblasts. Then the osteoblast will start releasing cytokines, the osteoprotegerin ligand that will go and bind to the pre-osteoclasts. Then they will undergo differentiation to become mature osteoclasts that will start releasing enzymes and acids to digest the bone. The same osteoblasts, they can release osteoprotegerin, which is inhibitory. So it's also referred to as osteoclastogenesis inhibitory factor. So this factor, it will function as a decoy. It can go and attach to the osteoprotegerant ligand, so that these ligands, they are not overstimulating the pre-osteoclasts to differentiate into the mature ones. So there is control. So it will inhibit bone digestion. That's what I mean. So this diagram is summarizing all that. So we have the osteoblasts with the receptors for parathyroid hormone and also vitamin D. If there is less amount of calcium, the parathyroid hormone will be secreted. It will come and bind to the osteoblasts that are depositing the bone tissue. But the osteoblasts, they are going to be stimulated to release a cytokine which is called osteoprotegerant ligand that goes and binds to the pre-osteoclasts to activate them, and then they will differentiate into the mature osteoclasts that will develop a ruffled border, releasing enzymes from the ribosomes and also releasing acids. So you can see the acids that are being released there. The acids will cause dissolution of minerals. The enzyme will cause digestion of the matrix. So the collagen fibers, the ground substance, will be digested by the enzymes. This is called bone resorption. So you mobilize calcium phosphates from the bone. That's why under the influence of parathyroid hormone, there will be an increase in calcium because calcium is being mobilized from the bone tissue. There is control to this. The same osteoblasts, they can also release osteoprotegerant protein that is inhibitory. So it's going to inhibit the interaction between osteoprotegerant ligand with the pre-osteoclast because they will act as a decoy. So they are going to be binding to osteoprotegerant ligand. So if you have a complex of osteoprotegerant with the osteoprotegerant ligand, then there will be less activation of the pre-osteoclast, less maturation of the osteoclast, and then there will be less digestion. So it will control bone resorption. That's what I mean. Okay, so same information. So we proceed with bone deposition and absorption are normally in equilibrium. So bone deposition and absorption, they are in equilibrium. That will provide the strength of the bone. For you to have a stronger bone, you need to deposit bone and mineralization. After some time, the bone will be becoming brittle. So to avoid that, you need the osteoclasts to digest the old bone so that the osteoblast now comes in and deposit a new bone. That will provide strength for the bone. Otherwise, when you are aging, you have less of the bone deposition. You are going to have more of the old bone, which is brittle and is more prone to fractures. So you can have fractures at your old age. Normally, except in growing bones, the rates of bone deposition and absorption are equal. The osteoclast usually exists in small but concentrated masses and erode the bone for about 3 weeks, creating a tunnel. So they are digesting the bone, so they will create a tunnel within the bone. Then the osteoclast disappear, then the tunnel is invaded by the osteoblast. New bone begins to develop because now the osteoblast will start depositing new bone in those tunnel that has been created by the osteoclast. The bone deposition then continues for several months, the new bone being laid down in successive layers of concentric circles, the lamellae, on the inner surfaces of the cavity until the tunnel is filled. So until the tunnel is filled now. Deposition of new bone ceases when the bone begins to encroach on the blood vessels supplying the area. So once the bone tissue is encroaching on the blood vessels, the deposition of the new bone will cease there. There will be control because otherwise they will be embedding the blood vessels or blocking the blood vessels in the central canal. The canal through which these vessels run, called the Harvesian canal. The Harvesian canal is all that remains of the original cavity because much of that cavity has been filled by the bone. So only the Harvesian canal will remain, which is the central canal that will contain blood vessels. So each new area of bone deposited in this way is called an osteon. Bone remodeling, I've already explained to say you need deposition of new bone because the old bone becomes brittle, and this old bone, which is brittle and weak, is more prone to fractures. So you need deposition of new bone that will provide the strength. That is called bone remodeling. So you have deposit of new bone, mineralization, it becomes old and brittle, you need to digest it. So you have the osteoclast that will come in to digest, to create tunnel or cavities within the bone, and then you have new osteoblasts that will deposit new bone. So that's the remodeling of the bone that is taking place in an individual as you are growing. But in old age, you find that the deposition of new bone is minimized, so you have more of old bone that is brittle and more prone to fracture because it's weak and fragile, so it can actually break to some extent, so it can have fractures. Okay, so the same information when there is a fracture, you know, to say you need a healing process to take place there. There will be deposition of new bone that will form a callus because of the deposition of new bone. The osteoblast will be very active. They will deposit new bone there to try to seal the fracture there. So you find that there will be a lot of osteoblasts that will start depositing bone, then it will join the two ends of the bone after a fracture. So the fracture can heal because of the activities of the osteoblast. But the strength in the structure of the bone is affected by the activities, especially how much stress you are giving the bone. The more stress you are giving the bone, the more it's going to deposit new bone. So it become heavier and stronger. So you find that bone of athletes become considerably heavier than those of non-athletes because they are exercising their bones. So because of the stress that you are subjecting the bones to, they are going to develop to try and overcome the stress itself. A leg in a cast becomes thinner compared to a leg which is not encased. So you find that if you have the POP, there is atrophy of the muscles, there's also atrophy of the bone itself. The bone becomes smaller. If you're exercising the bone, then it becomes larger. If you're not exercising the bone, it becomes smaller. It's all about the stress that you're subjecting to the bone. The bone stress also determines the shape of the bones under certain circumstances. Healing of fractures in children, the formation of the callus, I've already explained there, how the fractures are going to. Okay, so with that information, we are done with bone physiology. Then the next part of the lecture will look at the parathyroid hormone and calcium metabolism. What is the function of the parathyroid hormone? So for the sake of this lecture, not to be 2 hours or 3 hours, we are going to end here. Then I'll record the next part. Thank you very much.